classifying a busy hospital waiting room, and you will see how healthcare systems manage downtime. Patients and families wait in a highly passive state. Because of this environment, many medical professionals view the introduction of art into a hospital as a simple distraction. It is often categorized as a recreational activity, an afterthought designed to pass the time while the actual medicine takes effect. Modern medical curricula correct this bias directly. Formal training requires practitioners to establish strict clinical demarcations around the use of art in a medical setting. Medical art therapy operates under tight parameters. It is distinct from general art education, and it requires far more expertise than wheeling a cart of paints into a pediatric ward. Classifying the practice as recreation neglects the underlying clinical architecture and leaves a validated medical intervention unused. Formal medical education defines medical art therapy as a rigorously structured intervention. Executing it safely requires strict adherence to precise operational and psychological protocols. To understand its utility, we first have to map the exact boundaries separating a clinical intervention from a casual art activity. We then need to detail the specific therapeutic modalities, examining how visual expression targets distinct psychological and physical deficits. Finally, we must examine its systemic integration, which includes uncompromising safety standards and multidisciplinary referral networks. The validity of medical art therapy relies entirely on how it is operationalized, bounded, and embedded within a quantitative healthcare system. Throughout history, human beings have used visual expression to process complex emotion and trauma across every major civilization. Undergraduate medical training strips away that romantic history. To operate in a hospital, a practice must demonstrate measurable clinical utility. This boundary map divides visual practices into 3 categories. First, recreational art, unstructured distraction with 0 clinical goals. Next, art education, structured but purely skill-based with no clinical relevance. Finally, medical art therapy, a sharply isolated overlap where visual expression meets documented medical objectives. The materials do not define the therapy. It is defined by clinical intent, the mandatory presence of a trained therapist, and strict alignment with the patient's overall medical trajectory. Moving beyond the basic definition, postgraduate application requires a clinician to diagnose exactly how art should be deployed for a specific patient. A central patient assessment splits into 3 therapeutic tracks. First, psychological support. Directed art making helps patients articulate nonverbal trauma. Second, insight and self-awareness. Analyzing aesthetic choices helps patients subconsciously adapt. Third, rehabilitation. The tactile process rebuilds fine motor skills and neural pathways. Executing these modalities requires a specific aesthetic proficiency. The practitioner must possess the clinical training to translate a patient's visual output into actionable psychological data. These interventions are highly targeted. A modality is prescribed based on the patient's specific phase of treatment and their physical capacity at that exact moment. Applying these 3 tracks proves medical art therapy is an active, dynamic intervention, demanding continuous clinical reasoning, rather than the passive provision of art supplies. The scope of this clinical reasoning extends beyond the individual patient. Curriculum standards dictate that the therapy must serve multiple distinct categories of people within the healthcare facility. This infographic outlines the specific cohorts: primary patients with acute or chronic illness, family members managing secondary trauma, and healthcare providers facing severe burnout. The intervention is customized for each group, providing a necessary psychological off-ramp for highly stressed individuals across the entire ward. By managing the psychological health of the caregivers and the support network, the therapy actively improves the overall systemic quality of patient care. Identifying a psychological need is useless if the intervention cannot be executed safely within a highly regulated hospital environment. The art therapist cannot operate in a silo. Multidisciplinary integration is mandatory. This network diagram illustrates the referral workflow. A primary physician or psychologist initiates a needs-based referral, dictating the therapist's operational boundaries. The art therapist must then ensure their qualitative work supports the broader quantitative medical treatment plan. This mandatory clinical integration also strictly dictates the specific physical environment and baseline conditions where the therapy sessions must occur. Foundational undergraduate requirements mandate that therapeutic environments adhere strictly to uncompromising hospital standards. This includes rigid infection control protocols, baseline safety procedures, and stringent quality assurance measures regarding all materials and space. Without these referral protocols and infection control standards, the therapy becomes a liability. Systemic integration is what validates the practice. Pulling back to view the entire patient journey, we see how the insights gained during these sessions translate back into clinical data. The aesthetic breakthroughs achieved in medical art therapy integrate as qualitative data points, informing the broader treatment strategy. This data improves the patient's capacity to cope, leading to better compliance with harsh medical regimens like chemotherapy or physical therapy. This continuous, closed-loop communication is the hallmark of a postgraduate level medical integration. Medical art therapy bridges the gap between treating a physical disease and treating the human being experiencing the disease. Practicing in this field requires a dual competency: the foundational operational discipline to maintain infection control and the advanced clinical reasoning to execute psychological modalities. This strict operational reality exposes the initial bias, the idea of art as a mere distraction, as a complete misunderstanding of the discipline. The formal curriculum proves this bias obsolete. When properly deployed, visual expression is a highly calibrated instrument for building psychological resilience. Medical art therapy, when bounded by strict clinical demarcation and integrated into a multidisciplinary medical team, serves as a vital component of modern, holistic patient care. Art in healthcare is not about making the hospital look better. It is about making the patient actually get better.